as has the patient had loss of consciousness and has remained unconscious? Has the patient lost consciousness and regained consciousness? Very different differential diagnoses. Or, and the first would lead you either coma or cardiopulmonary arrest. The second would lead you to the causes of transient loss of consciousness, which are the 4 S's: syncope, seizure, stroke, and sugar, otherwise known as hypoglycemia. But what can you extrapolate from the words that are being used either on the triage board in your emergency room or in your clinic or the case presenter's mind? If somebody had come in a coma, we probably would use coma. If somebody had come in an arrest, we'd probably use arrest. So I would predict that loss of consciousness here is transient. Otherwise, more sinister problems might have popped up. And the more sinister problems might be ventricular fibrillation or brain herniation. So assuming that the loss of consciousness is transient, the key question is to understand the nature of what happened before, what happened within, and what happened after. Pre, intra, post isn't just a kidney problem. It applies to the world of LOC. So what would be helpful before? If before the patient got loss of consciousness, was there any cardiovascular trigger? Was there any neurological trigger, like neurological symptomatology, like numbness or tingling on one side before the patient lost consciousness? The intra helps a lot. A sequence of events is very important. So if a patient loses consciousness and then has rhythmic movements, that's more likely to be syncope. If the patient has rhythmic movements and then loses consciousness, that's more likely to be seizure. The post is the best part and the only part that is as accurate as can be, because often you are there with the post part. And if you hear a murmur, it's probably syncope. If you see a lateral tongue laceration, it's probably seizure. I'll just share some pearls about what's not helpful pre, intra, and post. What's not helpful pre is anchoring too much on it because it's data long gone and has altered by time and memory. What's not helpful intra is movements. Movements can be part of seizure or syncope, and movements in relation to loss of consciousness can be helpful. What's not helpful afterwards is urinary incontinence. Urinary incontinence characterizes both seizure and syncope. So we've talked a lot about loss of consciousness, and we've assumed that it's transient by virtue of the fact that those were the words chosen, but that might have been an error, and the error might land us towards coma or cardiopulmonary arrest. If in fact it's transient, then we'll apply the 4 S's: seizure, syncope, stroke, and sugar. By the way, there's a 5th S, which I'll keep in my back pocket to keep you engaged. I'll tell you later. I'll pass the mic to Charmaine for any additional reflections and back to Kirtan afterwards.
You're just amazing. I had nothing to add. That was awesome.
Sure. So for the second aliquot, I would try to paint the picture as much as I can. So at an altitude of 40,000 feet, aboard a 16-hour long flight, and 4 hours into the flight, at 3 o'clock early in the morning, the cabin crew announces that if there is anyone who is a doctor or nurse on the flight, and a doctor was indeed present, and he reaches to the cabin crew to help them. Cabin crew draws his attention to a seemingly 30 to 40-year-old person who was traveling alone, and they found the foams coming out from his mouth, and which led them to announce for the need for help. And as you can imagine, that past medical history is unobtainable because the patient is traveling alone, so we have nobody else to ask for. And we thought that maybe we would check his luggage, but then again, if you don't know that if that person is unconscious and if nobody knows him, then how can you find his luggage in the overhead bins, right? The medications, again, unobtainable. Family history, social history, and allergies are also unobtainable. And that's the end of aliquot.
Ooh, in-flight emergency. Kirtan, you're such a fantastic storyteller. So we are right in the intra, as Robbie was describing. We are seeing someone who has foaming in the mouth, appears young, and who is altered. When it comes to the in-flight emergencies, it's very nerve-wracking because we're just so used to having our tools and being in our controlled setting, and we're just further removed on a plane high up in the air, but there are resources available. So every plane has a kit. And the other thing that you can also help be ask for help is like other passengers. So the chances of somebody having a glucometer, if the kid usually has it, you know, it's high on the plane. So kind of like it's kind of like you have to Sherlock Holmes on the flight a little bit. And the other thing to note is that every single plane, they do have, they're associated with physicians that are on the floor. So the cabin crew can call to have more assistance from someone who is like emergency medicine usually trained down in the floor. So you're not alone. So if you are walking into the scene, take a deep breath and let's go. So I think like at this moment, what I would ask is for whatever resources I have, like getting a vital sign. There is a blood pressure cuff, there is a monitoring available, there is a stethoscope that is not great, but worth the try. It's kind of like those C. diff stethoscopes that we have. I think in this term, his young age, is notable. So kind of going back to what Robbie was mentioning in terms of like the 5 S's. So thinking about a seizure with someone who's like foaming in the mouth, thinking about he's like probably too young for a stroke event. Hypoglycemia is known. And the other thing is like substances. I think a lot of the time it's people who are coming on plane, they might have some anxieties, like take prophylactic medications, mixing that with some alcohol. So thinking about substances as well would be informative. And then like doing a quick exam to see what we see is like where I would start for this patient. Robbie, what additional thoughts?
Absolutely superb. I feel like for those of you who may not know about Charmine's clinical propensity, she's a master of acute medicine. And in fact, the first time we ever really worked together was in the craziness of a first day intern managing a patient who was critically hypotensive. And so it's really cool to see that come out in VMR. It often doesn't because we have plenty of time to think, but I have nothing to add. That was absolutely superb. All right, Kirtan.
Yeah, amazing differentials. So now for third aliquot, it comes down to physical examination. So when we check the pulse of the patient, then we find that it's around 120 beats per minute and it's rapid and steady pulse. We are not able to measure the blood pressure immediately, but the SpO2 seemed fine. And upon general examination, the patient, kind of aroused upon stimulation, but still the patient appeared anxious and confused. And you can spot the few drops of perspiration on the forehead and brows. When you do the pen torchlight examination, then you find that the patient has dilated pupils and which are unreactive to light. And as for the neurological examination, there are no motor or sensory deficits. But apart from that, as you can imagine that due to the constraints of airplane and other commotion going around, you can't do a more thorough examination. But as of now, this is all the data that you have. And then after this aliquot, I would reveal final piece of data and that would reveal the diagnosis.
Kirtan, this is a superb exam. I commend you for looking at the pupils in this case. I think that's amazing. And I think I'll just focus on them because I think we don't rarely get to practice the pupillary exam. So the first thing you want to know about pupils in an ideal setting is what the baseline pupillary state is, because patients can have reasons to have one or both pupils distorted because they just visited the ophthalmologic office and did a dilation, or they have surgery. And so when we're analyzing the pupils, we're often making the assumption that they were previously normal and only the pathology we're entertaining is changing them, but that can be flawed. And so assuming that these pupils were normal and were reactive to light and now are dilated and unreactive to light, essentially the conclusion we come to is the patient has excess sympathetic tone. And that's what dilates the pupil and allows you to run away from the tiger or my absolutely crazy dog this morning, who I ran away from many times. So why would the sympathetic tone be higher? That often is because of excess sympathetic activity, but you have to stop and wonder, could this be because of excessive anticholinergic activity? So before you go down too much sympathetic tone, ask yourself, could this be too much anticholinergic tone? The support for too much anticholinergic tone comes from the fact that the pupils are unreactive to light. That tends to be a characteristic feature of anticholinergic toxicity, which, as Charmine already kind of alluded to, may be a med effect that the patient took. But a big point against anticholinergic toxicity is the presence of diaphoresis. The anticholinergics prevent you from constricting your pupil and prevent you from sweating. So the fact that the patient was sweating on his forehead, another subtle and great pickup from Kirtan, is more robust an argument against anticholinergic toxicity than the support for it by the unreactive pupils. So it's a little bit of a seesaw effect, but the presence of diaphoresis overwhelms that finding. So now you're in the world of sympathetic toxicity, and before you should then say, is it systemic or local? Because local sympathetic toxicity can come from local issues, like the patient's having eye drops that are sympathomimetic and can make the only pupils dilated, but not be systemic. That's when you look to the rest of the body, and the patient has marked evidence of sympathetic toxicity in the rest of the body, namely the sinus tachycardia. Provides great evidence, and so does the anxiety. And so the key question is this endogenous or exogenous sympathetic toxicity? Endogenous sympathetic toxicity refers to that discharge of sympathetic tone from things like seizure, hypoglycemia, hyperthyroidism, pheochromocytoma, severe pain, and things of that nature. Exogenous means the patient took something like caffeine, which would be an extreme form here, or albuterol, which we see quite a bit, or illicit substances, such as cocaine or methamphetamine. There are some syndromes that you should know about that result in sympathetic toxicity, like serotonin syndrome and NMS. But here, the confusion is that the time course here is very helpful. You don't know the exact time course, but you know that it has to be less than 4 hours because the patient presumably self-boarded the flight. And for me, that makes it a priority to think about two things. Could this patient be hypoglycemic, or could this patient have had a seizure? Or could the patient have had both hypoglycemic seizure? What would I do practically? You probably don't have the ability to measure a glucose unless you're lucky enough that a passenger has a glucometer, but you probably can empirically treat for the possibility of hypoglycemia. You probably also have access to benzodiazepines, not officially, but also through probably another passenger. So my immediate steps would be to give this patient orange juice or something, making sure that they can swallow it, and to have as a backup therapy, get access to some benzodiazepines, primarily through probably other people. Those are my reflex thoughts, which really center on Kirtan's great pupillary exam. I'll pass the mic to Charmaine if there's anything to mop up, but I'm really, really intrigued and very impressed by Kirtan's incredible exam skills.
That was phenomenal, Ravi. I totally agree with you. And in terms of the in-flight kits, I did a presentation on them when I was in med school because I was very fascinated by that. And it was very funny because they have dextrose tablets, but they don't have a glucometer in the kit, and it blew my mind at the time. I'm not sure if it's updated or not, but I 100% agree is if the patient is able to, if he's not altered enough and can take something, getting him some sugars or just asking for passengers for help, that would be what I would do as well. That was masterful, RG, as always.
Sure. So amazing thoughts, friends. And you know what Rabi mentioned is very important, because imagine this, that at 3 o'clock in the flight, usually what happens that when air crew is not actively serving the food to the people, and since it's an overnight flight, the light should be so dim. So you can imagine that everything is in the darkness. So in darkness, the pupils will be dilated, even physiologically. But the fact that on doing the torchlight examination, when you focus the light on eyes and still they are remaining dilated, and it definitely means that it is not physiologic, right? So that is really important what Ravi said. And now the final record, I kind of consulted the air hostess who actually drew my attention that what actually happened. I was asking her again and again that can you describe the scene to me, right? So on further probing the air hostess, she described that she first noticed the patient kind of shaking before the loss of consciousness. And then, I asked her that, can you describe the shaking movements? Were they high amplitude movements? What was the frequency? Of course, not the exact frequency, but what it looked like. And as from her description, it seemed as if she was referring more to the patient being kind of, jittery or shaking rather than convulsions. So that was the final piece of data. And with that in mind, what do you think, friends?
Kirtan, you're just the best. Uh, that's masterful history taking. And again, like using the resources you have to the best of your ability and trying to make as much possible out of them. And this is incredibly helpful to notice that the shaking before the loss of consciousness. And I love how Robbie just set us up for success from the beginning, talking about like the intra, after, and the after. I think this is like concerning for seizure to me. And I think the things that I would do if the patient is already alert, then that's good. If not, it's making sure the patient can lay on their side. It's just protecting that airway. And I would still like thinking about a young person, while we don't have the entire, we can't do any labs, just like the hypoglycemia one is the one that we can like manage in that situation. If there are like substances on board, then that just requires time. But I think at this point, seizure is number one. Syncope is a great mimicker of the seizure as well. I'm not getting really a sense of that here. But I think at this time I would be most concerned about a seizure. Why he sees? That's a good question. I think, again, trying to rule out the metabolic causes of that. And then also, hopefully, when the patient is more alert, you can ask about like past history of epilepsy if he's on anti-epileptic on those, then getting more targeted questions. For now, just protecting his airway, making sure he's safe, checking on his vital signs and respiratory status until he's more alert. RG, what are your thoughts?
I couldn't agree more. I think I'm right there with you with my analysis, and I also would add what Kirtan was emphasizing about the time. And there's a lot of things that we learn in medical school happen early in the morning. Acute myocardial infarction happens. A drop in cortisol, the peak cortisol levels happen to drive that, which also is an opportunity for you to test for adrenal insufficiency in the morning. But also late at night is a powerful trigger for seizures. Seizures tend to be nocturnal events for people, which is a part of the explanation of sudden death in epilepsy. So unfortunately, a lot of patients can seize with their face down, and that may result in apnea and death from epilepsy. So the timing here, 3 a.m., is also in line with seizures. I think it's very tricky to what the conclusion that Kirtan came from the description of the movements, which seem to be to him more rhythmic than convulsions. And the rhythmic activity may represent a withdrawal syndrome from something like alcohol. So his breath may be pretty helpful here, because if there's enough alcohol intoxication or withdrawal, sensing that from using your smell, which we don't often use in clinical medicine, may be helpful. But then again, that goes back to the alcohol withdrawal seizure potentially as a hypothesis for alcohol intoxication seizure. But I want to make sure you don't miss another important S, and that fifth S is this. Ready? One sec. I'll show you the fifth S. See it right there? That's the fifth S. I want to make sure this patient isn't sleeping. There are fascinating syndromes of deep, deep sleep, including a recent NAGM case that I'm sure that Kirtan read. So please, please, please don't think that this patient's sleeping, but know that things like cataplexy can actually be pretty prolonged. And there's some very fascinating conditions that can cause people to not wake up at all, even with very vigorous activity. But I think the actionable step here is benzos and sugar, which Charmaine mentioned a long time ago. So I'll pass the mic to you, Kirtan, to take us home.
Sure. So, you guys got it right there in the first aliquot itself. So if we think about the dilated pupils and the perspiration beats, the rapid thready pulse, and, kind of shaking or jitteriness movement, so you immediately think that what if this is indeed hypoglycemia? And maybe it is possible that the patient has some predisposing factor for hypoglycemia that we don't know. Even if patient has consumed the meals on airplane, we don't know if the patient is chronic alcoholic or if the patient has cirrhosis, something which can impair the gluconeogenesis. At 3 o'clock, it can lower the glucose levels, right? So I immediately requested the air crew team to make sure that, you dissolve the sugar in the water. And again, what Ravi pointed, that if the patient is not completely conscious, and if we give them sips of water, and what if the patient aspirates, right? So that was definitely a concern. So immediately what we did, that we prepared the paste of sugar and kind of deposited in the mouth of the patient. And then as, patient was doing well, we kind of give him the sips of water. So like within few minutes, it was all good. He was back to consciousness. And but again, now the thing is that should we probe deep into the history? Like, of course, I was asking him that, do you have such conditions before? Do you have epilepsy or whatever, right? But the thing is that we are in the midst of a flight, right? So the patient is surrounded by so many other people and there's definitely a commotion. So you can imagine the patient would be shy, right? It's not a perfect time to ask such complicated questions. So I was like, okay, no worries. I would come back later when everybody has, fallen asleep again. And then I would probe deep into the history because I don't want to make patient feel intimidated during that moment. And interestingly, this is what happened. Why I titled the case as Framing Differentials in the Sky, because so I was looking at the patient and just after a few seats, there was another girl and she was also standing there and she was looking at what I was doing. So I was intrigued that what if she is also a doctor and she is just observing. So I asked her that, hey, madam, are you also a doctor? And she was like, yes, I'm a PGY3. And I am like, my God, please come here, please examine him and let's make sure that we are not missing anything, right? So she came over, she also examined the patient, she did the motor examination and everything. She made sure that patient was not aspirating. And then, I asked her that, what are your thoughts, that what could be this and what are some of your differences? So she told me that, well, Kirtan, see, we are driving at a very high altitude, at around 30,000 feet it was. So maybe, hypoxia could be contributing to this. We don't know the baseline condition of patient. What if the patient has obstructive sleep apnea and in the COVID times we wear the masks, right? So, with mask on, it could be difficult. So what if this is hypoxia? So that was one differential which we considered. Then of course, as you and Sharmin mentioned, that what if this is a transient ischemic attack or maybe even a seizure? Now, even if it's a TIA or stroke, there is nothing that we are going to do which can help the patient, right? I mean, if we find the motor deficits which persist, then maybe we can somehow, make sure that flight lands at the nearest destination and we can give the patient the stroke care because you can't provide stroke care on flights, right? So that was one differential. And another differential was intoxication. Like maybe the patient has alcohol withdrawal, the maybe, patient had some symptomatic abuse or whatever. But the thing is that since it was fixed immediately by the sugar, we thought that, well, hypoglycemia was the best, option. And we actually came to that common conclusion that hypoglycemia explains everything best. But the last part which Sharmin mentioned, that in order to seal the diagnosis of hypoglycemia, you need the Whipple's triad, right? That first you need to document the hypoglycemia, then the symptoms of hypoglycemia, and then the resolution of symptoms upon treatment. So we have the two components, that we have the symptoms and the symptoms resolved, but we don't have documentation of hypoglycemia because there was no glucometer kit available. And I'm sure that even if it was available, in that moment in commotion, you won't think of, asking air hostess that, hey, can you get me a glucometer? It's just not going to happen, right? So that was very critical part. Now, what happened, that after 4 hours, I went back to the patient. The patient was asleep, so I was like, my God, I don't want to wake him up. So again, I went back after 4 hours and now, he was like drinking water. So I asked him very gently that, hey man, are you all right now? And he was like, yeah, I'm good. Many people are asking me this, what happened to me? And I'm like, you don't remember? And he's like, no, I don't remember. I vaguely remembered that I was unconscious, I was confused, but I don't know what happened exactly. And then I asked him that, I'm sorry if you are uncomfortable, but can you tell me that, do you drink alcohol occasionally, things like that? And he answered yes, that he drinks alcohol occasionally. And when I, asked him a more critical question that, like, do you think that you drink a bit too much, something like that before the flight? And then he didn't answer it as no, but he was, not, what I can say, he was not in a perfect state to answer that question because of course he was shy. But from his reactions, I could imagine that he meant to say that he is a chronic alcoholic indeed. So, now we have a little bit of hypothesis that we can frame, that because of chronic alcoholism, maybe the hypoglycemia can happen in such critical times because the glucose stores are not enough in the body. And that was the perfect explanation at that time. And I hope that that was the case and patient doesn't develop any, TIA or stroke later on when he lands. And we hope that that was only the case. So this was the case and I loved it because I had a colleague from whom I can take the help on flight. It was so reassuring for me.
I don't even know where to begin that reflection, honestly. I'll just let it stand for itself as a marker of the team spirit, the humanity, the obsession with clarity and knowledge growth, and also the kindness and politeness not to push somebody beyond their comfort zone. And I think whatever this diagnosis is, you can only speculate on it. And I think you can call it a time plus sugar induced relief of loss of consciousness. And is it because time or sugar or whatnot? But I think you've taught us a lot today, Kirtan, a lot. And I think me talking just takes away from the power of what you just did. So I'll pass the mic to Charmaine for her closing reflections on what is a very unique, wonderful, eye-opening, and probably unrepeatable CP Solver's VMR experience. So thank you for making it. And I look forward to your next flight back to the United States, where we hopefully, for the patient's sake, don't have another surprise. But if we do, I'd be thrilled to learn from it again.
What Robbie just said, and I'm just very grateful that you were on that flight with this person. So good job, friend. So proud of you.
Thank you. And last thing I will briefly mention that, as you know, that a few days back, Professor Rez actually tweeted that the most recent NEGM interactive case, it was actually titled as Up in the Air. And it was also a similar case. The patient developed some complication on the flight, and he tweeted that, so you won't believe that, when we were leaving the flight after 16 hours long flight, I actually mentioned this to the air cabin crew that, hey, do you know, like we have this journal like NEGM, like they don't know what is NEGM, right? So I had to explain them that we have this journal, and like few days back, the case was, similar to this, we have emergency. It was kind of deja vu for me. And thanks to that case that I had some insight what to do. So I'm sure that they were probably thinking that, what is this crazy guy telling to me about NEGM and stuff like that? Like we don't know NEGM, right? But I was so excited that I told them that, I read that case and I'm sure it was a terrible experience for them, but it all went well in the end.
Oh my gosh, I don't even know what to say. And I think the only thing that is even close to matching Kirtan's epicness today is Emery's backup career as a stand-up comedian in the chat. I don't know, you all, before you leave this meeting, you should just watch everything from the beginning till the end. Emery has just been dropping humor after humor. And I'll read her final reflections for you, which is that she's grateful that you're flying with CP solvers and wants you to store any clinical knowledge pairs as we approach our final destination. Remember to always fly CP solvers where you connected worldwide. Yeah, if you're still on this, unfortunately, people who are watching cannot see Emery's hilarity in the chat. But if you're engaged, open up the chat, please. Enjoy Emery's wisdom. All right, Franco, take us home, please.
I love the case. I love everything of this session. So let's go for teaching point. First, we listen some amazing approach for LOS, and we learn about the 5S: syncope, seizure, stroke, sugar, meaning hypoglycemia, and sleep in some conditions like cataplexy. Then we learned that a good approach is to frame timing clues. Before, if there wasn't any prodromals, neural, cardiovascular signs and symptoms, intra, where are the time of the movements, and after, if you listen to a murmur or if there is a lateral tone lesion during the LOS. There could be also misleading clues during timing that can be present in both etiology, like neurological or cardiovascular. Before time, it is historical independent, so we don't want to anchor too much in the story. Intra, the movement can be related to cardiovascular or neurological etiologies. And after, urinary incontinence can be related to cardiovascular or neurological etiologies as well. Pupils in LOAs. Be aware of the base state of the pupils. Sometimes they could be dilated because of an ophthalmologic procedure. If there is normal base state that you should always assume, you should think that dilated pupils are excess of sympathetic tone, probably due to endo issues, thyroid issues, or like a pheochromocytoma, or exogenous causes like coffee, albuterol, or abuse of substance, versus an anticholinergic tone excess. Like it will be helpful to pick up unreactive that they're unreactive to like, or if there is mucosal or skin dryness concomitant with the LOS. And when you find it, if you find there is a seizure or if it's slightly likelihood of a seizure, you should always protect the airway first. And if after the patient is conscious, survey for an epileptic history or look for immediate reversible causes like hypoglycemia, like was suspected in this case.
Absolutely amazing, y'all. Thank you for a wonderful experience, and we'll hope to see you all tomorrow for RLR. Bye.